In the last 5 years, there's been a huge increase in our understanding of the molecular basis of acute myeloid leukemia, and in particular, meticulous stratification of the mutational landscape at diagnosis in patients with AML. And this work has had profound influence, firstly in terms of refined prognostication, and so combined with cytogenetics, the mutation analysis that's now possible to deliver can identify refined prediction of patient outcome if treated with chemotherapy alone. The second really important question, which is going to become increasingly a talking point, is it allows us to characterize the clonal structure of residual disease in patients who appear to have achieved a CR. I think it's particularly important in the use of hypermethylating agents where there may be a rationale for delivering an additional agent in CR patients, perhaps a targeted agent. It's also identified a number of potentially druggable targets. So the recently reported RATIFY trial led to midostaurin recently receiving approval in the United States. This was a study where, by adding the FLT3 inhibitor midostaurin to intensive induction chemotherapy and consolidation in adults with newly diagnosed AML, there was an improvement in overall survival. And finally, it's giving us some quite important insights into how we might improve outcome after allogeneic stem cell transplant. This is an area that's sometimes ignored, but with increased donor availability and the ability now to deliver transplants in fit patients up to the age of 75 with relative safety, an allograft is becoming a central part of the treatment algorithm of the majority of adults with AML, particularly older patients who are fit. And yet, up to 60% of patients are destined to die of relapsed disease. And we've really made very little progress in reducing disease relapse. So one of the areas which we in Birmingham and others have been developing actively in the last few years is the notion that post-transplant maintenance, either with pharmacological therapies, either targeted therapies or agents with broader anti-leukemic specificity, or cellular therapy, may be a very promising way of improving outcome by reducing relapse risk. And it may do that simply by manipulating the kinetics of relapse so that relapse comes later when there's a more potent graft versus tumor effect, or you may be able to identify drugs that directly manipulate the alloreactive response, drugs such as azacitidine, which plausibly have the ability to upregulate a graft versus tumor response by increasing expression of tumor antigens. But if you're thinking about designing maintenance strategies, it's really important to understand a bit about the molecular structure of relapsed disease. And what we were able to do in a collaboration with colleagues in Oxford, led by myself and Parish Vyas, was to identify that using next generation sequencing, about a third of the patients who relapse after a transplant have an entirely distinct mutational profile compared with their diagnostic mutational profile. And that suggested to us that we may, if we're designing maintenance strategies, want to be using agents with a broader anti-leukemic specificity, such indeed as hypermethylating agents, or conceivably checkpoint inhibitors, or even cellular therapies. And that actually, if you were to choose and use only targeted therapies based on the diagnostic fingerprint, then it may be that quite a lot of patients relapse without that mutation.